Okay, so chapter 22, it's about the digestive system. Oops. So, the digestive system has organs that can be located in the in the head region and moving into thoracic region, abdominal region, in the pelvic region. So it is an organ that it goes from the oral cavity up to the anal cavity, and it has two major portions: the gastrointestinal or digestive tract, which is also known as alimentary canal, through which you have a series of hollow organs that allows the passage of food from the oral cavity up to the anal cavity. And then we have accessory organs. So the accessory organs aids in digestion in some way, includes the teeth, includes the liver, pancreas, salivary glands, gallbladder. So all of those are accessory organs. Here is the physical view of all of these components of the digestive system. So here's the oral cavity. In the oral cavity, we have the tongue, we have paired salivary glands, major salivary glands, like the parotid glands that we have here on the top of, or on the surface, external surface of the masticatory muscles. We have the submandibular glands that are protected by the body of the mandible, and they have the sublingual glands that are located below the tongue. And these are paired major salivary glands, but we have minor salivary glands as well that are scattered throughout the oral cavity. And now, posterior to the oral cavity, we have the shared part of the pharynx that is shared by the respiratory system and the digestive system, which will be the oropharynx. And then the oropharynx inferiorly communicates or connects to the esophagus, which is the hollow tube that brings the food from the pharynx into the stomach. The stomach, it's a reservoir of food that it has like an inverted J shape. It's located in the left upper quadrant. And this stomach ends in the first part of the small intestine, which is the duodenum, which is this. So here is the oropharynx, continues as the esophagus, and below the diaphragm, we have the starting of the stomach, which is this, and the stomach ends in the duodenum, which is the first part of the small intestine. The small intestine is a series of loops. It's a muscular organ. So the first part of the small intestine is the jejunum, and the last part is the ileum. The ileum connects to the large intestine. So this is an extended version, and this is an in situ version. So the large intestine has the beginning portion, which is called the cecum, that it's like a little dilation here. And posterior to the cecum, we have the vermiform appendix. And then superiorly, going on the right side, the cecum converts into the ascending colon, and then you make a right to left turn that is going to be the hepatic flexure. And it's called hepatic flexure because this is the liver or hepatic gland. And then the large intestine run from right to left, forming the transverse colon, which is this. And then this transverse colon takes a downturn that is going to be called the splenic flexure. This is the spleen, just next to the stomach. And then the colon is going to go down, and it's going to be called descending colon. And then you will have an S-like turn that is going to be called sigmoid, and then you have the anus. So those are the major parts of the alimentary canal. And then for the secondary or accessory organs, we have the tongue, the salivary glands. We have the largest gland in our body, which is the liver. And the liver has two lobes, the right and the left, that are seen anteriorly. And inferiorly, we have the view of the two minor lobes, which will be the caudate and quadrate lobes. And then underneath the right lobe of the liver, we have the gallbladder, which is a reservoir for bile, which helps to emulsify the fats, make them easily digestible. And then behind the stomach, in the retroperitoneal space, we have the pancreas. The pancreas secretes digestive enzymes and also secretes endocrine hormones like insulin, glucagon, somatostatin that regulates the levels of glucose. Digestive enzymes help us to break down foods like proteins, lipids, carbohydrates. And then the pancreas and the gallbladder empties into the second portion of the duodenum. And those are all the accessory organs. Functions of the digestive system: ingestion or intake of food and water through the mouth. Secretion. We have glands like the pancreas that secretes enzymes and secretes hormones. Secretion of acid by the stomach. Secretion of mucus from most of the alimentary canal, so that the food can propel easily, can move from proximal regions into distal regions without eroding the walls of the alimentary canal. And then we have minor hormones, local hormones that are secreted within the large and small intestine, so that we can aid in digestion. And one of the aids of these hormones in digestion is allowing greater movement of the gastrointestinal tract, or better secretion of, and more secretion of mucus and acid. Propulsion, which is rhythmic contractions, regular contractions, so that you can have transfer of food from proximal regions to distal regions. This is known as peristaltic movement. Another function will be mechanical digestion. You can break down largest pieces of food starting in your mouth by crushing it with your teeth, and then transferring to the stomach. And then the stomach, all these semi-solid or solid pieces of food or liquid pieces of food that you ingest, or the liquids that you ingest, it will blender them. It's like a blender, the stomach. It will create a paste that we know as chyme. It will combine it with the secretions like the acid, the mucus, some enzymes to start that chemical digestion. Chemical digestion involves enzymes that breaks down the chemical bonds between the nutrients like proteins, carbohydrates, lipids. The purpose of both, it is to absorb nutrients so that we can assimilate these nutrients, we can repair our cells, we can grow, we can store energy, and use that energy for later when we are not eating. Functions includes of the digestive system absorption. We not only absorb nutrients, but we also absorb water, electrolytes, like sodium, potassium, calcium. We absorb vitamins, and we transfer those from the alimentary canal into the blood and lymphatic vessels, because we have lymphatic vessels and then we have blood vessels that helps to distribute all of these water, nutrients, electrolytes into the different cells that requires them. And then we eliminate what we don't need. This is the process of defecation. So defecation is the exiting of ingested materials that are not digestible, and that material is known as feces. So all of these functions are carried by the alimentary canal, while the accessory organs helps for the processing of these foods, because they don't come in direct contact with the food. Only their secretions contact the food. So they aid in chemical digestion. Now, our organs of the digestive system that are located in the abdominal cavity, which are most of them, are protected by the peritoneal membranes. We have two. We have the visceral peritoneum internally, and externally we have the parietal peritoneum. Now, the visceral peritoneum, which is the one that is in close contact with these intra-abdominal organs, it can have different names depending on which organs it connects. Like if it's connecting the small intestine, it will be called mesentery, and in this mesentery you have the blood vessels and nerves and lymphatics that provides oxygen-rich blood and the liver, the CO2-rich blood back into the circulatory system. So this mesentery is rich in blood vessels and also in nerves. And now, another name for this visceral peritoneum, but when it is in close contact with the colon, it will be called mesocolon. And a general name will be called serosa. And the space that it is enclosed by the parietal peritoneum will be the peritoneal cavity, and it will be filled with peritoneal fluid that helps to lubricate the organs as they move. Now, the mesentery and the mesocolon helps to also connect these organs into the posterior abdominal cavity, so that within the circumstances, gravity doesn't act so much in them, so it keeps them tight. And as we have the movement, hopefully we don't have twisting of these loops of intestine, which sometimes it can happen. If you have twisting of these loops of intestine over each other, you will have necrotic tissue, because the blood vessels will be entangled there and you don't have blood circulation. Sometimes you call this volvulus. The one that is more likely or more prone is the sigmoid to twist. So now, anything that it is enclosed in the peritoneal cavity, any organ, is going to be called intraperitoneal organ. Most of these organs of the abdominal cavity, which are part of the digestive system, are intraperitoneal. Very few are retroperitoneal, or located behind the peritoneum. So if you see the abdominal cavity in a lateral view, you have the posterior parietal peritoneum. So anything anterior will be intraperitoneal, anything posterior will be retroperitoneal. And that includes the pancreas, part of the large intestine, like the transverse colon, and part of the duodenum. Now, the mesenteries then are folds of visceral peritoneum that helps to provide blood supply by giving a route for the blood vessels to go into the different parts of the intestines. And then the mesocolon attaches mainly to the transverse colon, the large intestine. Now, between one region of the stomach, which is called the greater curvature, and the anterior wall of the abdominal cavity, we have an apron-like membrane that hangs from the greater curvature that we call the greater omentum, just like as is written in there. So the greater omentum is like an apron. And in this greater omentum, we have fatty tissue. And this fatty tissue has a purpose. It helps to create a cushion between the intestines and the internal abdominal wall of the anterior abdomen. Our intestines move a lot. And if we didn't have this apron-like membrane, the greater omentum, our intestines will constantly hit the internal abdominal cavity, and this muscle, the smooth muscle that makes this wall of the intestines, is very fragile, so it will get damaged really easily. Not only that, but this greater omentum also helps to keep our intestines warm, so that the intestines move at a proper time and then transfer the food regularly from proximal to distal, allowing for digestion to take place. If we didn't have that, our digestion will be so slow because the movement will be so slow and the food gets spoiled inside our intestines. And now, between a region of the stomach that is called the lesser curvature and the liver, we have another omentum that in this case is going to be the lesser omentum. And just like that, the greater omentum has fatty tissue in between the membranes. So this is the lateral, or well, sagittal view and anterior view of the abdominal cavity. So this is anterior, this is posterior, these are the body of the vertebrae. This is the muscles of the anterior abdominal wall. This is the liver, so this is the sagittal view of the liver. Here is the stomach, the open view, so this is the stomach cavity. So here we have the lesser omentum connecting the liver to the stomach. And then here we have the greater omentum. And internally, our peritoneal cavity, it is covered by the visceral peritoneum, and externally we have the parietal peritoneum, which is all these. Organs that are retroperitoneal will be the pancreas and the duodenum. And it's not shown in here because this, I don't know why they don't show it, but we have also the kidneys in this region. So the kidneys are retroperitoneal. And as well, the transverse colon. And these are loops of small intestine hauled into the posterior wall by these mesenteries. The rectum is also retroperitoneal. Now, in the anterior view, if you lift the greater omentum, which will be here, you will be able to see the mesentery. So this is the mesentery proper, and this will be the mesocolon. This is the transverse colon. This is the descending colon, sigmoid, and then anus and rectum. Questions?
So is the sigmoid considered part of the colon?
Mm-hmm. It's just having different names. Mm-hmm. So this is sigmoid, this is descending, transverse, and ascending is on the right. So then if you let this greater omentum go down, it's hanging from the greater curvature of the stomach, covering the anterior surface of the small intestine and part of the large intestine. And again, I mean, this is the being the cadaver is only fatty tissue here. But remember, fatty tissue, what it does in our body is adipose tissue, connective tissue. It helps to protect organs, important organs. So it's a cushion. And also helps for warming, insulating the organs. So in this case, we'll be insulating the small intestines so that they can move appropriately. And then again, here's the liver, right lobe, left lobe, gallbladder, and between the liver and the lesser curvature of the stomach, which is this, we have the lesser omentum. And this is the greater curvature of the stomach. So this is the greater omentum.
So Professor, does the lesser just stay on top, or does it also go all the way down to the bottom?
No, it stays.
It stays up there.
Yeah. Problems that can occur is infections of the peritoneal cavity or chemical irritation, no matter what it is. Inflammation of the peritoneal membranes will be called peritonitis. It's a medical emergency. You have to have a surgery to correct the problem. This can be usually due to abdominal trauma, peritonitis. Sometimes you can have ruptures of ulcers within the gastrointestinal tract, especially in the stomach. And the acid of the stomach is supposed to be only in the stomach. It doesn't go into the intraperitoneal cavity. So if you have an ulcer in the stomach, it ruptures, then the acid is going to go there and it's going to create problems. Now, since you're going to have irritation, some of the muscles that are surrounding the abdominal cavity are going to respond by contracting more, and the anterior abdominal cavity is going to feel very hard. Okay? And then if you touch during palpation of the abdominal cavity, and then you let it go like this, your fingers, after you palpate, the person will have something that is called rebound tenderness. So no pain is having the person won't have pain when the pressure is applied, but after you release the pressure, the person will feel pain. So that's rebound tenderness. And the person has to have surgery when it has peritonitis, and then they give antibiotics as well as part of the treatment. Now, the blood supply to the stomach comes from splanchnic circulation, which is provided by celiac trunk, superior mesenteric, and inferior mesenteric, which are the three anterior branches of the aorta. Superior mesenteric first, celiac trunk first, superior mesenteric, and then inferior mesenteric. Celiac trunk gives blood supply to the spleen, the stomach, the pancreas, the liver, and the stomach, while the superior mesenteric provides blood supply to the small intestines and the first half of the large intestines. Inferior mesenteric provides blood supply to the second half of the large intestines. And when it comes to drain of the blood, the blood, it is drained by the hepatic portal vein, which is a branch of the mesenteric veins, and also the splenic vein and the gastric veins. And the hepatic portal vein carries nutrient-rich blood. And then the liver will process this nutrient-rich blood. It will create glycogen as a storage form of glucose. It will also make proteins. Most of the proteins in our body are made by the liver. And then the rest of the nutrients will be stored as fat tissue. And now, after processing this food-rich blood, the blood from the liver will go into the hepatic veins and then drain into the inferior vena cava. Blood supply into the abdominal organs, it comes from branches of the ANS, like sympathetic nervous system, parasympathetic system, and also the enteric nervous system, or ENS. So the three main clusters will be for the ANS: celiac plexus, superior mesenteric plexus, and inferior mesenteric plexus, just as the names of the arteries that provide the blood supply. And those nerves actually follow these arteries. They use it as a route to go and bring these nerves into the specific areas of these organs of the alimentary canal. Now the ENS, it is very large plexus. It is located only in the abdominal cavity, and it helps to control the secretions and movement of the alimentary canal locally. Now, the vagus nerve, which is part of this parasympathetic system, this one plays a role in also the movement of this gastrointestinal tract, but also in the secretion. And one of the reasons why parasympathetic system is called rest and digest is because the vagus nerve increases in general the rate of movement of the gastrointestinal tract, and also increases the secretion of the glands of the gastrointestinal tract so we can digest. That's why it's called rest and digest. But locally, the enteric nervous system, with its billions of neurons, it helps to control local movement and secretion of hormones that aids in digestion. Now, for the walls of the gastrointestinal tract. So from internal to external, we have different layers. The most internal layer will be the mucosa. So this mucosa is made out of an epithelium. Most of the epithelium will be simple columnar with goblet cells that secrete mucus. But in the oral cavity and in the esophagus, we have stratified squamous epithelium. And in certain parts of the oral cavity, like in the hard palate, in the anterior part of our gums, the gums that faces just anteriorly, we have a stratified squamous epithelium with keratin. And this is the most protected type of epithelium. The reason for why we have it there is because it's the first part that it is in contact with food. And if that food is abrasive, or if it's the temperature very high, we need to have that coat of keratin to protect our teeth, our roots of our teeth with the gums. And then the hard palate is found at the roof of the oral cavity. That's where, with the tongue, we compress the food up to create a bolus, a compact ball of food. And that compression requires to have an epithelium that it is stronger, which is a stratified squamous epithelium with keratin. Underneath our tongue, we have a very thin epithelium. If you drink liquids that are very hot, it falls there into that area, it hurts a lot. It's where you burn the most because this epithelium is very thin. Okay? And in our tongue, we have a stratified squamous epithelium in the dorsum. In the bottom part, we have a thinner epithelium. Now, the esophagus, it has a stratified squamous epithelium without keratin. And just remember, a stratified squamous epithelium, we have it also in our skin, but in this case, we have it with keratin. And other places where we have stratified squamous epithelium without keratin, what will be the vagina? And also, we have it in the esophagus, areas that are subject to friction. So as the food is transferred from the oral cavity into the stomach, well, we need to have a strong epithelium in the esophagus just in case that the food that we ingest is not highly moisturized. So we can protect the deeper layers of the wall of the esophagus. Now that epithelium is held into place by those connective tissue that we call lamina propria. And underneath this lamina propria, we can have lymphatic vessels, blood vessels, glands, and MALT, mucosa-associated lymphoid tissue, especially in the large intestine, like the small intestine, in which we call it Peyer's patches, and also in the stomach, we have lymphoid tissue. And then the next layer of the wall of the alimentary canal is going to be the muscularis mucosa. So we have 2 layers of muscle in most of the alimentary canal, with the exception of the stomach, where we have 3 layers of muscle. The first layer is going to be circular, and the outer layer is going to be longitudinal. With the circular, we can compress and then do not allow the passage of food, so we can retain it proximally, or we can open and allow the passage of food. And with the longitudinal, what you do is you just shorten the length so that you can transfer the food much easier from proximal to distal, faster. And these muscles that we have are smooth muscle cells. So they are under involuntary control. Now the submucosa is made of dense irregular connective tissue, and also we have there blood and lymphatic vessels, and then we have submucosal glands that are very active to secrete mucus into the surface of the epithelium, so that the epithelium will be lubricated, and then you have passage of food really easily from proximal regions to distal regions. We have a plexus of nerves that is called submucosal plexus. And then we have nerve clusters of enteric nervous system. And with this submucosal plexus, or the ENS plexus, we control movement of blood into the area, so we allow more blood flow, and we allow also the production of secretions of mucus. So you can release more mucus or less into the surface of the epithelium with the submucosal plexus. In the muscularis externa, we have the myenteric plexus. Myo means muscle. So is the plexus that controls the muscles, the contraction of the muscles of the gastrointestinal tract. This plexus is also known as plexus of Auerbach, and is part of the enteric nervous system. It regulates the movement of the gastrointestinal tract. Now, the last layer is going to be the serosa or adventitia. It is connective tissue that helps to hold these organs to the surrounding tissues. It anchors them. So in areas like the peritoneal cavity, in this serosa or adventitia, you can have simple squamous epithelium and loose connective tissue. And this serosa, it would be called, when it is found in the peritoneal cavity, while adventitia outside of the peritoneal cavity, like in the thoracic cavity. The esophagus has adventitia, while the rest of the organs of the alimentary canal have serosa in the peritoneal cavity. That's where you have this simple squamous epithelium and loose connective tissue, and in the adventitia you have dense irregular connective tissue. Questions? So here is the layers. So here is the lumen, or the opening of the gastrointestinal canal. This is the epithelium. Is, as I said, majorly is simple columnar epithelium with goblet cells. And then you have the muscularis mucosae. Sorry, this is the layer, the muscularis externa, that has the circular layer and the longitudinal layer, not this one. This is the mucosa here. And then the mucosa has a muscularis layer. And then in here, we have the submucosa with this submucosal glands that has a duct that drains mucus into this lumen so that you can have additional lubrication. And then here we have, in this layer, in the submucosa, we have lymphatics, blood vessels, and nerves. And this submucosa is made of dense irregular connective tissue. Now the next layer, which is the muscularis layer, that's where we actually have the inner circular layer of muscle and the outer longitudinal layer of muscles in most of the gastrointestinal tract, except in the stomach. In the stomach, we have an additional layer, which will be the oblique layer. And the reason why we have this additional layer is because the stomach not only can do this contraction with the circular layer and then longitudinal contraction with the longitudinal layer, but also can do a ringing motion like this, so it can mix the contents that goes into the distal portion to the proximal region, like if it was a blender. It does this type of movement so that it can have better mixed motions, or motions to help to make a more homogeneous paste, which we call chyme. So in these muscularis layers is where we have the myenteric plexus, or plexus of Auerbach, that is part of the ENS that helps to contract these layers. And then we also have blood vessels, and then we have nerves. And then we have here serosa, which in this case will be will be inside in the intraperitoneal cavity, and if it's outside, like in the esophagus, in the thoracic cavity, will be adventitia. So this is connective tissue. So the regulation of motility, it is given by the nervous system and the endocrine system. So now, what type of muscles can we have in the digestive system? So mostly we have smooth muscle, in the alimentary canal, with the exception of the oral cavity where we have skeletal muscle, also in the pharynx and the superior portion of the esophagus. The superior third of the esophagus is made of skeletal muscle, but then the second and third distal portions of the esophagus are made of smooth muscle. And in the anus, we have skeletal muscle. Now, for sympathetic system inhibits the movement of the alimentary canal, while the parasympathetic system stimulates the movement of the alimentary canal. And these systems have complementary function. They are active at the same time, but one will be more active than the other depending on how much food content you have within the alimentary canal. And then both of them connect into the CNS and form part of the control system that we know as long reflex, while the ENS provides short reflexes that controls the movement. So here it is, ENS form part of the short reflexes, and they are limited to local neurons that are located in the sacral plexus. Now we have the endocrine system with hundreds of hormones that act locally, and they can provide movement to the stomach, small intestine, large intestine. And with that movement, you can control digestion as well. So they can stimulate or inhibit motility of the alimentary canal. So questions about the motility of the intestine, the control, the alimentary canal? Okay, now details about the oral cavity. So the oral cavity is the start of the digestive system. It is in charge of ingestion, so basically intake of food. Also, it starts doing physical and chemical digestion. Physical digestion by breaking down pieces of food with our teeth, and chemical digestion by start breaking down with enzymes, carbohydrates, and lipids. We have an enzyme that is called lingual lipase that starts breaking down the bonds between lipids. And then we have an enzyme that is called salivary amylase that starts breaking down starch. So starch-rich foods, we have potatoes, corn, etc. And then with the mouth and the tongue, we start forming a clump of food that we call the bolus. And that bolus will be passed into the posterior part of the oral cavity. Then we elevate the pharynx, and the pharynx widen. We close the nasopharynx so that the food won't go into the nose. And then the pharynx acts as a funnel. So it receives the bolus of food, and then when we elevate the tongue against the against the roof of the oral cavity, then we pass that food into the pharynx, and the pharynx is made of three muscles, three constrictor muscles, the superior, middle, and inferior. So the superior relaxes, receives the food, then contracts, and then the middle relaxes, receives the food, and then contracts. Then the superior relaxes, and the inferior relaxes, so the food will pass from middle constrictor area into the inferior constrictor area, and then the inferior constrictor contracts and passes the food into the esophagus. And actually the superior constrictor forms circular layer that closes the upper part of the esophagus, so this is the superior esophageal sphincter. And then the esophagus, the superior part, is made of this skeletal muscle, the inferior constrictor, and up to there, we can control voluntarily the vomiting. If the food passes into the second third of the esophagus, the food by peristalsis automatically will move into the stomach. So now the posterior part of the oral cavity has two openings on the, two boundaries on the sides, and that is called fosses. And in the middle, we have a fleshy extension of the soft palate that we call the uvula. So what are the borders of the oral cavity? Superior will be anteriorly the hard palate made by the palating processes of the maxilla and the maxillary processes of the palating bone that makes the hard palate. And then the posterior part, that is the soft palate. Laterally, we have in the oral cavity proper, we have the lateral portion of the upper and the lower arches of teeth. And then anteriorly, we have the incisors and the canines that forms the anterior border of the oral cavity proper. The oral cavity proper is anything internally to our teeth. And the vestibule will be outer to our teeth. So, and between, of course, the teeth and the cheeks and the lips anteriorly. And then posteriorly, we have the fosses. And then inferiorly, we have the floor of the mouth where we house the tongue. And then the lips are made by the orbicularis oris muscle, and externally are covered by stratified squamous epithelium with keratin. And we have the blood supply going to our legs provided by the plexus that we have in the dermis. So the lips are slightly reddish than the rest of the skin in our face. And the muscles of the tongue internally are extrinsic and intrinsic. So the intrinsic muscles help to give that shape to our tongue, and the external muscles, which will be helping us to move our tongue, they connect to different bones, including the hyoid bone and the temporal bone. Okay, so now the oral cavity is covered by a mucosa that we know as gingiva, and the gingiva in our teeth has a sulcus. That sulcus can be colonized by bacteria, and that bacteria can break down the tissue and then can cause gingivitis, and that can lead to destruction of the periodontal ligament that holds the teeth into the maxilla and the mandible, and you can lose teeth. Now, our lips are held into the gingiva by frenulum. So we have the labial frenulum that can be medial in upper and lower lips, and lateral. The lateral is close to the canines. Some animals, like horses or cows, their labial frenulum is very long, and whenever they're chewing, you can see not only the teeth, but also you can see the gums. Okay? And now, the space again between the lips and the cheeks is called the vestibule. While the space between the teeth, where we have the tongue, it is called the oral cavity proper. And then again, the palate is formed by bones from the maxilla and the mandible. That will be the hard palate, which is anterior. And then the posterior palate is soft, made out of muscles. So this will be the soft palate. And the uvula is part of these palatal muscles that hangs in the middle of the soft palate. And it helps to close the nasal cavity during swallowing. So here is the anterior view of the oral cavity proper. This is the vestibule, the space between the lips and the gums. So these are the gums, gingiva. This is the upper arch of teeth. This is the lower arch of teeth. This is the oral cavity proper, hard palate, soft palate, uvula, fauces. Posterior to the fauces, we have the palatal tonsils. In the roof of our mouth, in the oral cavity proper, which is all this, we have the tongue, and then we have a labial frenulum in here, 2 on the sides, also another one in here, 2 on the sides. And then we have a lingual frenulum, which will be here, that holds the tongue into place. So this is the mid-sagittal view of the oral cavity. So here are the intrinsic muscles of the tongue, and we have the muscles of the floor of the oral cavity, like the mylohyoid, craniohyoid muscles. And then connecting into the base of the tongue or laterally to the tongue, we have muscles like the styoglossus, hyoglossus muscles, palatoglossus, that they have different movements depending on the insertion and the origin. And then this is the posterior opening, the fauces, roof, floor, anterior opening. And then here we have nasopharynx, oropharynx, laryngopharynx, and then esophagus. So this pharynx is a muscular tube made by superior, middle, and inferior constrictor. The inferior constrictor is part of the esophagus, and we have an sphincter here that closes the esophagus, so that if you have reflux from acids from the stomach into the esophagus, those acids hopefully won't go into the larynx. But sometimes it can go and it can cause laryngitis. Questions? Okay, so the teeth. The teeth are connected into the alveolar processes of maxilla and mandible. And the root of the teeth are held into these bones by the PDL, periodontal ligament, which are short collagen fibers that makes a comphosis that runs in different directions. This PDL is very important. If you get infections or damage to these, more than likely you will end up losing a tooth. And we take them for granted, but a teeth, guys, or a tooth, our teeth or one tooth is like another bone in our body. You miss it until you lose them. They are very important for digestion. So the teeth are helpful for breaking down, the teeth are helpful for breaking down food in the process of mastication, which is basically grinding. And we have different types of teeth with different functions. The front teeth, which we have 4 in the maxillary arch and 4 in the mandibular arch, are known as incisors. They have a broad portion and a very sharp edge. These incisors help for clipping, for cutting food, grasping the food and clipping it. So the most broader teeth that we have are the central incisors, are medial. So, and then on the sides we have the lateral incisors. So here are the central incisors, and then we have the lateral incisors. On the sides of the incisors, we have these teeth that we call the canines. The canines have a sharp edge. This sharp edge helps to tear and grab strongly the food. So they have pointed crowns. So this is the crown of the tooth, We have two types of crown. We have anatomical and we have clinical. Anatomical crown is the crown that is covered by the hardest substance that we have in our body, which is the enamel. That's the anatomical crown. Anything that is covered by enamel will be in the anatomical crown. The clinical crown will be the one that is not covered by gingiva. As we age, the gingiva recedes, and we expose more of the anatomical crown. But anything that it is not covered by gingiva, it is the clinical crown. And now, then the canines are helpful for ripping and tearing. And then posterior to the canines, in adults, we have premolars. We have first premolar and second premolar. The first premolar is anterior, the second premolar is posterior. And they have a broad surface that faces superiorly and inferiorly that will be used for crushing food. So these premolars and the molars help to grind the food. Another name for this will be cusps, these teeth, and they are specialized for grinding. The premolars, they have a lesser surface area than the molars. But no matter what, both are equally important for grinding. Now, for molars in adults, we have three. We have first, second, and third. Sometimes the third, it doesn't erupt, and this is what we call the wisdom tooth, the third molar. Now, once we're born and we start having our teeth, the first set of teeth, this first set of teeth is called primary dentition. And then as we get older, we lose these primary teeth or milk teeth, and then we replace them by the secondary teeth or secondary dentition. And this is permanent, hopefully, if you take care of them. So then if you lose a secondary teeth or part of the secondary dentition, you don't have a replacement. And the primary, don't think like it erupt all at once. Well, we have periods of time where you have eruption of teeth accordingly, and then you start losing them also at certain periods of time in replacement with the secondary. While you have primary and secondary, you will have what is called mixed dentition. So another name for primary is going to be called baby teeth. And the secondary, we also known as permanent teeth. In primary dentition, we have 20. So teeth, we don't have 32 like in permanent. So we don't have premolars, and we have 4 incisors, 2 central, 2 lateral. We have 2 canines, and then we have 4 molars, first and second. And then they begin erupting around 6 months of age. They start with these first central incisors in the lower teeth, the maxillary. Looks very cute, and baby shows them to you. Look like little vampires doing this, showing you the first teeth. And then they end up erupting about 2 years old. So for secondary dentition, we have 4 incisors, 2 canines, 4 premolars, and then we have 6 molars, if you have them all complete. I mean, they don't erupt, but they will be there, the tertiary or the wisdom teeth. And then they start erupting these ones about age 6, and by age 12, all the deciduous teeth have fallen out, and then you start replacing them. The third set of molars can erupt between 17 to 21 years old, and sometimes they can cause trouble because they can be horizontally located like that and be pushing the second molar, can cause damage to these second molars in the roots. And the lack of eruption is known as impaction, and sometimes you have to take them out if they create a lot of problems. So here are the different types of teeth. So here are the primary dentition, the maxillary, and the mandibular teeth. So central incisors, the lower, erupt at age 6 months. Then the lateral incisors, 7 months. And then you have the upper incisors around 8 months. Then the lateral upper incisors like 9 months. And then you have your molars like between the first year and the second year. So these ones, you have like the first year molar and second year molar, and then the canines about a year and a half, either in the lower or the upper arch. And then again, we have 20 in total. We don't have premolars, and we don't have third molars. And usually they can be numbered 1 to 20 or with letters of the alphabet. Now for the secondary dentition or permanent, we have the central incisors that erupts between 6 to 7 years. Then the upper incisors, central incisors between 7 to 8 years old. And then we have the lateral incisors between 7 to 8 years old, at the same as the central incisors. Then we have the lateral upper incisors between 8 to 9 years old. Then you have eruption of the canines between 11 to 12 years old. And then that will be for the upper arch. The lower arch, it's a little bit earlier, like 1 year before these ones. And then we have the premolars, which erupt between 10 to 12 years old in both upper and lower arches. And then the molars between 6 to 13 years old for first and second, third between 17 to 20 years or 21. Questions? For the structure of teeth, so we have in the crown 3 layers. The outer layer, which is made out of enamel, the hardest substance in our body. Then underneath the enamel, internally, we have the dentin, which is yellowish, is calcified tissue. You have tubules that when exposed, they, because you have erosion of your enamel, they are sensitive to cold, hot liquids. And then internal to the dentin, we have a cavity that is filled with connective tissue with blood vessels and nerves. This is the pulp. And the enamel and the dentin are made of calcium hydroxyapatite crystals, just as the ones that we have in the bone. So the bone is not the strongest tissue in our body. First is enamel, then dentin, and then bone. And they are made of calcium hydroxyapatite crystals. So then what you can expect when someone has hypocalcemia, especially during pregnancy, that's why pregnant females, they're supposed to take extra calcium, you expect that the teeth becomes weaker in hypocalcemia. If you're a pregnant woman and you're forming bones for your own baby, you expect that the calcium comes from you. If you don't ingest enough calcium, guess what? Your teeth become weaker and also your bones. That explains so much why some females get broken teeth just right after pregnancy. Okay? And now in the root, we have a substance that is called cementum. And that cementum is surrounded by the PDL that holds the cementum of the root into the alveolar processes. And now the dentin has 70% hydroxyapatite crystals. And the odontoblasts are cells that makes the dentin throughout life. So here is the structure of a tooth. This is a sagittal section. So this is the crown, this is the root, this is the crown, this is the actual anatomical crown because it's covered by enamel. This is the dentin, and this is the pulp. The pulp has blood vessels, nerves, and the blood vessels and nerves enters into this part of the root, which is having an opening that's called apical foramen. So this is the apical portion of the root. So this is cementum surrounding this dentin, and these are the PDL. And then since we have here in this tooth, which by the way, the space between, or the region between the crown and the root is actually the neck. So now, since this part of the crown, the anatomical crown, is covered by this gum, this gingiva, it is the the clinical crown, while this is the anatomical crown. If someone has receding gums, the anatomical crown becomes larger and the clinical crown as well. Not larger, the clinical crown becomes larger. And then here we have the gingival sulcus, that some bacteria can come residing here and start with the enzymes breaking down the connective tissue here, and the person will have loose teeth. All right, so cavities are caused mainly by bacteria that can destroy the enamel, like Streptococcus mutans. These bacteria lives out of simple sugars, and they synergize Streptococcus mutans with other type of bacteria, and they release acids as they are using these carbohydrates, these sugars, and these acids are going to breaking down the enamel. So fluoride that is found in toothpaste or in water increase the hardness of enamel by helping to deposit this calcium hydroxyapatite. Now, excess of fluoride can cause staining of the teeth, of the enamel. So then, in order to keep healthy enamel, it is recommended to brush your teeth and floss regularly and reduce sugar intake and foods that are acidic in nature, like coffee, sodas, energy drinks, etc. Now, for the tongue, it's made of skeletal muscle covered by stratified squamous epithelium in the dorsum. It's held into the floor of the oral cavity by the lingual frenulum. And in the dorsum, we have the papilla of different types. We have filiform, that they don't have these gustatory cells, but helps to detect the texture of the food. We have a fungiform, circumvallate, and foliate papilla that has receptors for taste molecules. And then we have extrinsic muscles that helps to move the tongue, and these extrinsic muscles are innervated by cranial nerve number 12, which is hypoglossal. Now, for detecting taste, we use cranial nerve number 7 in the 2 anterior thirds of the tongue, and then in the posterior third, we use cranial nerve number 9 and cranial nerve number 10, glossopharyngeal and vagus nerve. So our tongue helps us to move the food so that we can propel it into the floor, into the roof so that we can compact it, and also move it to the side so that we can crush it with our teeth. So it's part of the process of mastication. And now the intrinsic muscles control the shape of the tongue and push the food against the hard palate. Now, for salivary glands, we have major salivary glands that are paired, like the sublingual, submandibular, which is also known as maxillary, and the parotid glands. The most active salivary glands will be the submandibular, produces more saliva than the parotid. The parotid are the largest physically, but they produce the second largest amount of saliva, while the submandibular produces more saliva. And then the smallest glands, which are the sublingual, they produce the less saliva than the other two. Now, then the parotid glands, they secrete 25 to 30% of the total saliva, and we secrete more or less like 1 liter of saliva per day. And parotid glands are located over the masseter muscle, this muscle in here. And these glands, they have a duct that is known as parotid duct or Stenson's duct that drains in the second superior molar on the sides, the second superior molar. These parotid glands can be infected by viruses like mumps virus, causing parotiditis. And then the submandibular glands produce between 65 to 70% of the total saliva, and they empty the saliva on the sides of the lingual frenulum by using the submandibular duct. And then the sublingual glands, they secrete also the saliva on the sides of the lingual frenulum together with the submandibular glands, but they use the sublingual duct. And these sublingual glands, they produce 5% of the saliva. So, our second superior molar, which drains the parotid glands, receives 25 to 30% of the saliva, while in the floor of our oral cavity, we receive up to 75% of the saliva, just underneath our tongue. What will be the clinical importance of secreting more saliva into the floor of the mouth than into the upper part of our mouth?
Swallowing purposes, to lubricate the bolus.
Swallowing and lubricating the bolus. That's true. But why we drain more saliva into the floor rather than the mouth? Sorry, in the roof of the mouth.
For protection?
For protection. By gravity, the food goes into the floor of the mouth. What if that food will be extremely hot? We have liquid there to help to prevent blood scalding into this area where we have very thin epithelium. Okay? Now, these are major salivary glands. We have minor. We have thousands of small salivary glands, but we don't have a name for them. But we have it in the hard palate, we have it in the cheeks, we have it in the vestibule, in the lips, internally. If you want to prove, and in these salivary glands, although they are minor and they don't have a name, they're as important as the major salivary glands. It keeps our different parts of our oral cavity lubricated so that the lips, they don't get stuck into the gingiva. So tonight, when you go and brush your teeth at home, you will do an experiment. You will be in front of the mirror in your medicine cabinet. You grab a tissue paper, retract your lower lip, and then dry it with that tissue paper. stay there. You will see opaque color in the epithelium until you see it again that it is moist. You will see the shyness of the saliva. Sometimes when people have dry mouth, if it's too extreme, not only the tongue sticks into the hard palate, but also the lips are so stuck into the gingiva. So that's the work of the minor salivary glands. And again, we have it everywhere, even the hard palate. So what type of cells does these glands have? They have serous cells, mucus cells, and serous cells, they secrete a water-based fluid with enzymes like salivary amylase. And in the saliva, we have majorly water and enzymes, but we also have IgA, we have lysozyme that breaks down the wall of bacteria, and then we have like urea, we can have a waste product, we can have salt, we can have potassium, calcium. And then mucus cells, they secrete a mucus-based saliva that continuously moistens this oral mucosa. The parotid glands only have serous cells, so it produces more watery saliva, while the submandibular glands have mostly serous cells and have small number of mucus cells, and the sublingual glands, they have more mucus cells. So this secretes 5% of saliva, but that saliva from the sublingual glands is very serous. Sorry, it's very mucus. It's much thicker. It's more protected. And again, because most of the foods by gravity tends to go into the floor of our mouth, and it can damage the floor of our mouth. So just really quick, this is the parotid gland over the masseter, extensors or parotid duct that empties into the second superior molar. Sublingual gland drains into the sides of the lingual frenulum by the submandibular duct, and then that sublingual duct that has 10 to 12 sublingual ducts, that has between 10 to 12 sublingual ducts empties into the sides of this lingual frenulum, and this is this is a histological view of these glands with mucus cells and serous cells. And this is the lumen of the glands. So, any questions?